Welcome to the Funnel Effect. Today we are conducting a deep dive into critical cardiological research, focusing on a condition that, well, it's often underestimated, sometimes misdiagnosed, and maybe even just ignored quite a bit. Moderate secondary mitral regurgitation, or SMR, in heart failure patients.
Yeah, that's right. And for this, we're drawing entirely from a really comprehensive state-of-the-art review published in the Journal of the American College of Cardiology, JACC. It's a fantastic piece that synthesizes, all the evolving evidence on this specific topic. And the author list is, well, it's a powerhouse. Mauro Riccardi, Matteo Pugliese, Carlo M. Lombardi, Stefan De Anker, Francesco Maisano, Javed Butler, Mariana Damo, Greg W. Stone, and Marco Metra.
Wow, yeah, that roster. That represents some of the world's top minds in heart failure and interventional cardiology. And they're tackling a really fascinating clinical dilemma, I think, because historically SMR is incredibly common in heart failure, right? But almost all the attention, all the resources seem focused squarely on patients with severe SMR. That's where the big trial's aimed.
Exactly. That's where the action has been. But this review, it really shifts the perspective. It asks this critical, maybe even slightly provocative question. What about all these patients sitting in that moderate category? When clinicians hear moderate, the instinct is often, well, just manage the underlying heart failure. But the data compiled here, it makes a very powerful case that moderate SMR has a significant and often overlooked prognostic impact. We arguably just can't afford to miss it anymore.
Okay, so our mission today as we dive into this source material is really to give you the context and maybe find those aha moments, bridging the gap between the academic side and what it means clinically. We need to unpack the prevalence, understand the subtle but serious risks it carries, and analyze those complex diagnostic challenges, especially since it's such a dynamic condition. And then finally, look at how treatments, both meds and interventions, are rapidly changing for these patients. We're going to find out, through the eyes of these researchers, why moderate SMR is really not so mild after all. All right, let's start right at the beginning. Let's ground ourselves in the pathophysiology because, as you said, SMR isn't a disease of the valve itself, is it? It's more about the heart muscle, the plumbing around it. So what defines secondary mitral regurgitation?
Right. SMR, or functional mitral regurgitation, as it's also called, it's basically blood leaking backward through the mitral valve. But it's secondary to some underlying disease in the heart's main pumping chamber, the left ventricle, the LV, or sometimes the upper chamber, the left atrium, the LA. The key thing, the absolute differentiator, is that the valve leaflets themselves look structurally okay. They're healthy. The problem is the geometry around them has changed so much, the chamber's dilated or remodeled, that the leaflets just can't close properly anymore. They can't coapt effectively.
Okay, so it's like trying to close a door, but the door frame itself is warped and pulled apart. The door might be perfectly fine, but it just can't meet the latch anymore.
That's a perfect analogy, exactly. And the review clearly splits SMR into two main types based on which part of the door frame is warped. First, and probably most common, is ventricular SMR. This is the type you typically see with heart failure with reduced ejection fraction, HFrEF.
The classic systolic heart failure patient where the LV is big and weak.
Precisely. The mechanism there is driven by that severe dilation and remodeling of the left ventricle. As the LV expands, it pulls the papillary muscles, those little muscles anchored to the valve leaflets. It pulls them outwards and downwards. This displacement causes the leaflets to sort of tent downwards into the ventricle, so they fail to meet in the middle and create a seal. The pump itself is pulling the plumbing apart, essentially.
Okay, that makes sense. And the second type,
Yeah.
the one gaining more attention, particularly with HFpEF.
Right, that's atrial SMR. This is much more common in heart failure with preserved ejection fraction, or HFpEF. In these cases, the ventricle might not be severely dilated. Instead, the main driver is isolated, chronic dilation of the left atrium, the LA. This leads to enlargement of the mitral annulus, the ring that holds the valve. It's often strongly linked to long-standing atrial fibrillation, AF, or issues with diastolic function. So instead of the pump pulling things apart, it's the upper chamber stretching the ring the valve sits in. And this distinction is really important because, as we'll get into, the treatment approaches for ventricular versus atrial SMR might actually be quite different.
That distinction makes perfect sense. Okay, so we know what SMR is, but now we hit this grading quandary. You mentioned the severity scale keeps shifting, and it seems heavily influenced by those big high-stakes trials from the last decade or so. Why is defining moderate so tricky?
It's tricky, largely because the definition of severe SMR itself has been, well, a moving target. Historically, guidelines define severe SMR using an effective regurgitant orifice area, an EROA, of just over 0.20 square centimeters. But studies, especially those leading up to the major trials, started showing that the actual shape of the regurgitant orifice in SMR, it's often crescent-shaped, not circular, meant that traditional echo measurements tended to underestimate how bad the leak really was.
Ah, so the numbers we were using for severe might have been too low. The thresholds got pushed higher.
They did, yeah. The consensus EROA threshold for severe SMR was pushed up, first to zero point 0.3, and in some contexts, even zero point 0.4 centimeter marks. This reflected the understanding that SMR often needs to be quite substantial before we label it truly severe, and that naturally leaves a very specific quantitative gap where moderate now sits.
Okay, let's nail down that gap. According to the ACCVI criteria, the review summarizes what are the key numbers, the metrics, for diagnosing moderate SMR or 2+.
Right, we need those numbers, but it's crucial to remember the implication too, not just the value itself. For moderate SMR, you're talking about a leak that's significant enough to cause turbulence, definitely more than trivial, but it's not quite reaching those catastrophic levels of severe SMR. So numerically, we're looking at an EROA the size of that hole between 0.20 and 0.29 centimeters reads. The regurgitant volume, RVol, how much blood leaks back each beat, is 30 to 44 milliliters. And the regurgitant fraction, or basically the proportion of the heart's effort that's wasted, is between 30% and 39%. So, at least 30% of the blood pumped might be going the wrong way, which is significant, but it falls short of the 50% or more you typically see in severe disease.
That quantitative framework seems clear enough, but it still didn't stop this huge confusion in those early big transcatheter repair trials. This is where we get into that famous conflict between Coet and Mitral, right? Same device, fixing SMR, but totally opposite results.
Oh yeah, they were absolutely critical landmark trials, but with completely opposing findings. The Coet trial was a huge success for MTER, that's transcatheter edge-to-edge repair. It showed significant reductions in both mortality, heart failure hospitalizations. But, and this is key, their patients had a relatively large mean EROA, around 0.41 centimeter FORs, so quite severe by most standards, and critically, only relatively mild underlying LV dysfunction.
Okay, so the ventral wasn't completely failing, but the leak itself was massive. The leak was the primary, or you could say disproportionate, driver of their symptoms.
Precisely. They were suffering because of the leak, more than just despite the leak. Now contrast that with Mitral FR. Their patients had much milder SMR overall, with a mean EROA of 0.31 centimeters, kind of borderline moderate severe. But they had much more severe LV dilation and dysfunction, and that trial, unfortunately, showed no benefit, no efficacy for MTER compared to medical therapy alone.
Wow. So if the heart muscle itself is too sick, just fixing the valve doesn't necessarily change the underlying prognosis. It sounds like trying to fix a totally broken car engine by just patching a leaky gas tank.
That is the perfect summary. And this forced a huge conceptual shift in the whole field. We moved away from just grading the leak severity based on a single number like EROA towards assessing the disproportionality of the MR relative to the LV disease. QRAPT picked patients with disproportionate MR. The leak was severe relative to the LV sickness. For them, fixing the valve helped dramatically. MITRA-FR, on the other hand, included patients with less disproportionate MR, where the LV disease was really the main prognostic driver. Treating the valve alone just wasn't enough to change their overall disease course.
That's the real aha moment here, isn't it? A simple EROA number isn't the whole story. You absolutely have to consider the entire clinical picture, the state of the ventricle, and whether the heart failure is potentially still salvageable if you fix the leak.
Okay, that diagnostic tightrope makes this next question even more concerning. How common is this moderate condition in the general heart failure population? And what are the actual clinical consequences if we don't address it?
Well, the prevalence figures are, frankly, staggering, especially considering we spend so long maybe not focusing on this category. Of course, the numbers vary a bit, partly because of those shifting definitions we just talked about.
Give us some of those numbers. How does it break down across different types of heart failure?
Okay, so in traditional HFrEF populations, the reduced ejection fraction group, the prevalence of moderate SMR reported in various studies ranges pretty widely, actually, anywhere from a low of about 5.8% up to over 32%. The large Bartko study, which looked at over 13,000 heart failure patients, reported about 14% prevalence, specifically in the HFrEF group, so, already quite common. 14% is already significant.
Yeah.
But the numbers get much higher when you look at the other end of the spectrum, the HFpEF patients, right?
They absolutely do. If you focus on heart failure with preserved ejection fraction, HFTEF, the prevalence of that atrial SMR type, remember, the stretched annulus ranges from maybe 7% to 14.4% in many studies. But when Bartko looked at the overall HF cohort, the prevalence of moderate SMR hit an astonishing 57% in the HFpEF group.
Wait, did you say 57%? Over half of HFpEF patients might have moderate SMR. That completely reframes how we think about that disease. It suggests this isn't some niche complications. It's almost standard, especially in older patients with stiff hearts and atrial issues.
It's incredibly ubiquitous in that population. And then if you look at the sickest patients registries focusing on advanced heart failure, like the HELP-HF registry, the prevalence of moderate SMR was 41.1%, regardless of their underlying LVEF. So this moderate condition is extremely common across the whole spectrum of heart failure severity.
What's also really telling, I think, is how even the major trials struggled to only enroll severe SMR patients. You mentioned earlier that trials aiming for severe SMR still ended up with a ton of moderate patients.
Yes, that's a crucial piece of evidence highlighting just how hard diagnosis can be and how dynamic it is. In the MHRA-FR trial, 52% more than half of the patients actually had a baseline EROA consistent with moderate SMR, not severe, when reviewed by the core lab. And in the later Reshape HF2 trial, that number was 53%. It just confirms that SMR severity can change, and it often gets downgraded when you have rigorous standardized core lab assessment compared to maybe the initial local read. What looks severe in clinic might end up being quantitatively moderate on closer inspection.
Okay, so it's common, hard to pin down definitively. Now let's hit the core argument of this review, the prognosis. The authors argue really strongly that moderate SMR is not benign. It's not something we can safely ignore.
That is absolutely the central message of the whole paper. The data confirms there's a continuous, escalating relationship between increasing MR severity, starting right from that moderate threshold, and adverse outcomes. It's a gradient of risk. In that big Bartko study, again, just having moderate SMR was associated with an increased risk of all-cause mortality. The adjusted hazard ratio, or HR, was 1.08 compared to those with no or only mild SMR.
Now, hazard ratio 1.08 might sound small to some listeners, but in big populations like that, statistically, that signifies a real clinically relevant increase in risk, doesn't it? It means these patients, on average, are dying sooner.
Exactly right. It's statistically significant and clinically meaningful. And the risk isn't just confined to one type of heart failure. That prognostic sting applies across the board. For patients with HFrEF, moderate SMR was linked to a 50% increase. That's 1.5 times the risk of all-cause mortality or heart failure readmission within just 90 days. That was from the Della Espriella study. It shows this moderate leak can accelerate short-term decline pretty dramatically.
And what about those patients in the middle zone, the HFMREF group, with LVEF between 41% and 49%?
Yeah, Abel and colleagues reported a 38% increase in all-cause mortality associated with moderate SMR in that intermediate group. So it still carries a significant prognostic weight, even if the EF isn't classically reduced. The leak is clearly stressing the system.
But maybe the most surprising finding, or at least one of them, relates to the HFpEF patients. They often have so many other health issues that can cloud the picture.
It is extremely surprising and very important. Even in patients with a preserved LVEF, so over 50%, moderate MR was found to be a powerful independent predictor of higher all-cause mortality. The JASPER registry reported an adjusted HR of 2.26 for death in this group. That's more than double the risk. It's a huge discriminator. And why so high? Well, it often suggests that the SMR in HFpEF is driven by that chronic severe atrial remodeling, the atrial SMR type. If that's present, it likely signifies a much more advanced chronic stage of the underlying disease, making the patient significantly sicker overall.
And it's not just about mortality. Moderate SMR also drives up the risk of specific events, like going back into the hospital.
Yes, definitely. Kataria reported an adjusted HR of 1.24 for HF hospitalization, specifically due to moderate SMR. And crucially, it also increases the likelihood of needing a heart transplant, HTX, across the entire HF spectrum. So, I mean, the data is really quite overwhelming when you look at it together. Moderate SMR is not a mild condition. It's an active and powerful accelerator of heart failure progression and mortality.
Okay, the fact that even moderate SMR carries such a heavy prognostic weight makes getting the diagnosis right absolutely critical. But we've established it's incredibly dynamic, which makes it a real tightrope walk for clinicians and echo techs. Let's get into the challenges with conventional imaging.
Yeah, the central challenge really is that SMR is just a moving target. Its severity can change substantially based on the body's loading conditions, how much fluid is on board preload, the resistance the heart pumps against after load, and just whether the patient is congested or relatively dry at the moment of the scan. Ideally, the guidelines say assessment should be done when the patient is stable and euvolemic, meaning optimally dry. But, in the real world, we often scan patients when they're admitted, maybe congested, undergoing big fluid shifts with diuretics. That's not always the ideal state.
And the standard tool, transthoracic echo or TTE, it has its own built-in limitations, right?
Yeah.
Especially in sicker patients.
TTE is definitely limited by physics sometimes. If you have a patient who's obese or on a ventilator, you often get suboptimal acoustic windows. It's just harder to get clear pictures. It's like trying to measure something accurately through a frosted, warped window, as you said earlier. And furthermore, the regurgitant jet itself, the leak, it's often eccentric. It doesn't shoot straight back. Plus, the actual opening, the hole, often has this sort of crescent or oval shape, not a nice, perfect circle. This
Yeah.
geometric reality often violates the assumptions built into the standard EROA calculations, and that frequently leads to an underestimation of the true severity.
Ah, okay. So a patient who might actually have severe leakage could get labeled as moderate just because the standard math didn't quite capture the weird shape of the hole.
Precisely, that's a real risk. Now, transesophageal echo, TE, is generally better because it gives much higher spatial resolution, a clearer view right from inside. You can see the leaflet coaptation better. But T requires sedation or even general anesthesia, and that often leads to temporary hypovolemia. The patient effectively gets dried out a bit by the process. This temporary drop in loading conditions can actually reduce the SMR severity being measured at that moment, again, potentially masking the patient's true baseline resting condition. It's an unavoidable complexity of the procedure.
Okay, so this inherent instability in the measurement issues,
Hmm.
this is why the review really hammers home the need for a multi-parametric approach, right? We can't just hang our hat on EROA alone.
Absolutely not. You have to use a combination of quantitative measures. You look at ERA, yes, but also RVOL, the vena contracta width, and critically that regurgitant fraction, the RFRAC. And RFRAC in particular really emerges from the data as perhaps the most crucial tool for identifying the truly high-risk patients hiding within that moderate category.
Explain that a bit more. Why is RFRAC such a powerful discriminator compared to, say, just the size of the hole, EROA?
Well, think of ERA and ARVOL as measuring the size of the leak itself. RFRAC, though, measures the consequence of that leak relative to the heart's total output, its total effort. It's the ratio of wasted blood volume going backward to the total volume the LV tries to pump forward. So if EROA is the size of the hole in the leaky pipe, RFRAC tells you that, say, 35% of all the water flowing through the system is actually being wasted down the drain. It gives you a much better sense of the hemodynamic burden, the inefficiency.
And the data really backs that up dramatically, especially that intermediate risk group classified as moderate SMR.
It does, quite strikingly. That Bartko study we keep mentioning, it showed that among patients who met the moderate SMR criteria based on ERO and ARVOL, if ever RFRAC was high, specifically 50% or greater, that subgroup had a massive, statistically significant jump in long-term mortality risk. The hazard ratio shot up to 3.02.
Whoa, an HR of over 3. That means for those moderate patients whose RFRAC is hitting 50% or more, their long-term risk of dying is basically tripled compared to those with lower RFRAC. That's huge. It essentially tells the heart team, okay, this patient might be quantitatively moderate by EROA, but functionally they're behaving like someone with severe disease. Half the pump's effort is wasted. That's a system under extreme stress.
Exactly right. It helps us pick out the patients who are already running on fumes, despite the moderate label. And beyond these standard quantitative measures from echo, we really need to look towards advanced imaging to truly capture the dynamic reality and the underlying heart condition.
Okay, let's talk about those. First, exercise or stress echocardiography.
Yeah, stress echo is recommended for those sometimes frustrating patients who seem perfectly fine lying on the echo table, but then get profoundly short of breath with any real activity. It helps unmask dynamic SMR. The review highlights that if a patient's EROA increases significantly during exercise, the paper suggests a cutoff of more than 0.13 centimeter C of increase. That large jump is strongly associated with reduced exercise capacity and significantly poorer outcomes, particularly in HFrEF. It's an objective way to see the valve failing under stress.
And then we have what's considered the gold standard for measuring volumes, cardiac magnetic resonance imaging, or CMR.
Right. CMR is seen as the criterion standard, mainly because it can accurately quantify ARVOL, RFRAC, cardiac chamber volumes, and LVEF without relying on those geometric assumptions that can sometimes trip up echocardiography. It offers better reproducibility. But its value goes even deeper for prognosis. CMR can directly visualize and quantify myocardial fibrosis scarring in the heart muscle using a technique called late gadolinium enhancement. Fibrosis is a really powerful independent marker of poor prognosis in patients with SMR. So CMR lets us assess not just the leak, but also the underlying damage the leak might have caused or be associated with.
Okay. And then computed tomography, or CT, comes in mainly for planning procedures.
Yes. CT is invaluable for procedural planning, especially for transcatheter interventions. It gives incredibly high-resolution images of the detailed anatomy of the mitral valve apparatus, the size and shape of the annulus, the leaflet structure, the relationship to coronary arteries, and the coronary sinus. This is all absolutely essential information to have before you go in trying to clip or cinch the valve.
All right, moving into management. We've firmly established that SMR is a secondary problem, right? It results from an underlying issue in the LV or LA. So the review makes it crystal clear that the absolute foundation of treatment has to be guideline-directed medical therapy, GDMT.
Absolutely. Non-negotiable first step. Maximize GDMT. The evidence showing its power is really quite compelling. One key study cited in the review by Spinka and colleagues showed that up to 36%, more than a third of patients who initially presented with moderate SMR, showed significant improvement, even complete resolution of their SMR after just a few months of optimizing their GDMT.
Wow, over a third just get better by treating the heart failure more effectively.
Yeah.
That raises a critical point, though, doesn't it? If GDMT alone can resolve SMR in so many patients, why are we even talking about spending money and taking risks with interventions like MT-EAR for the remaining moderate group?
That is the essential clinical dilemma, you're right. The reason we still consider interventions is because of the other, roughly 64%, who don't improve significantly on GDMT alone. They remain symptomatic, and we know from the data we just discussed that their prognosis is poor if that moderate SMR persists. For those patients, treating the leak itself might become necessary because the medical therapy just couldn't fully reverse the adverse remodeling that caused the leak in the first place. The review specifically highlights some of the contemporary GDMT classes that have shown a direct, measurable impact on reducing SMR severity.
Okay, let's touch on those. SGLT2 inhibitors, they're kind of the new cornerstone for HF treatment now. How do they specifically affect the SMR leak?
Right, SGLT2 inhibitors, SGLT2I, like ertugliflozin, studied in the EFFORT trial, they showed a significant reduction in EROA. The full mechanism is likely multifactorial, but a key part is that they cause the body to excrete more glucose and sodium, leading to a diuretic effect. This reduces overall cardiac volume and congestion. It reduces preload. By taking some of that volume stress off the dilated LV, it allows for some degree of favorable reverse remodeling, which in turn can lessen the mitral leaflet tenting and reduce the leak. And importantly, this reduction in ERO is significant even in the subgroup with moderate SMR, meaning EROA less than 0.30 centimeter at the
Okay, and the other big class, angiotensin receptor neprilysin inhibitors, ARNIs, like sacubitril, sartan.
ARNIs offer perhaps an even more comprehensive benefit for SMR. By inhibiting neprilysin, they boost the body's own natriuretic peptides, which leads to reductions in both preload and afterload. That's already helpful. But arguably, the most critical effect in this context is promoting left ventricular reverse remodeling. When the LV actually starts to shrink, even slightly, the overall geometry improves, the papillary muscles get pulled back into a more favorable position, and the leaflets can co-opt better. The PRIME trial demonstrated this beautifully. Patients randomized to ARNI had about a 30% decrease in their EROA compared to only a 9% reduction in those just getting valsartan alone. It actively helps remodel the ventricle in a way that reduces the leak.
So GDMT is absolutely foundational. Beyond the pills, there are also some non-valvular device interventions that can indirectly help SMR by improving the underlying heart mechanics. Let's talk about cardiac resynchronization therapy, CRT.
Yeah, CRT is a well-established therapy for certain HFrEF patients, specifically those with a wide QRS complex indicating electrical dyssynchrony. By pacing the heart simultaneously from two different spots in the ventricles, it improves the coordination of the contraction. This improved synchrony directly helps reduce SMR severity, partly by promoting that global LV and LA reverse remodeling we talked about, but also, importantly, by resynchronizing the contraction timing of the papillary muscles themselves.
So if the muscles holding the valve leaflets pull at the right time together, the valve closes better.
Exactly. And while we don't have large randomized trials looking specifically at CRT for moderate SMR, the available data does show a clear benefit. One study showed that about 25% of patients who started with mild to moderate SMR saw at least one grade of improvement in their MR severity after about a year of CRT. So it's an indirect fix, but it definitely helps the valve function.
Okay, pivoting back to that atrial SMR subtype, the stretched annulus, often linked to AF. What role does managing the atrial fibrillation itself play? Specifically, pulmonary vein isolation, PVI.
PVI for AF has shown some really compelling results in reducing SMR severity, specifically for that atrial SMR phenotype driven by the annular stretch. The thinking is if you successfully treat the AF, the left atrium might shrink or at least stop dilating further, allowing the mitral annulus to regain some of its normal size and shape. And the data supports this. One study looked at patients with LV dysfunction undergoing PVI. Before the ablation, 23% had moderate ML curie. After the PVI, a remarkable 70.5% of those patients showed a reduction in their MI severity. That high success rate really supports targeting the AF as a way to treat the associated atrial SMR in appropriate patients.
Lastly, what about patients needing TAVR for aortic stenosis? They often have moderate SMR just sort of sitting there as a bystander issue. Does fixing the aortic valve help the mitral valve?
TVR, transcatheter aortic valve replacement, can sometimes improve SMR. By replacing the stenotic aortic valve, you reduce the afterload on the LV, the resistance it has to pump against. This can lead to favorable LV remodeling relatively quickly, which might reduce the SMR. However, the data here is notoriously inconsistent. You see huge variability in the results. Some studies in high-risk TAVR patients report SMR improvement in only about 3% of cases, while other studies report success rates as high as 82%. This massive range likely stems from differences in patient selection, how bad the underlying LV disease was to begin with, and whether the SMR was truly just due to high afterload or if it was driven more by severe intrinsic ventricular remodeling. So while TAVR can help SMR, it's definitely not a reliable primary treatment strategy for it.
Okay, so we've maxed out the meds, we've considered CRT or PVI if needed. If our moderate SMR patient is still symptomatic despite all these foundational efforts, now we face the big question. Should we try to fix the valve directly? First, let's quickly touch on surgery. Is that an option here?
Generally, isolated surgical correction specifically for moderate SMR is strongly discouraged. It's not currently recommended in any major guidelines. The reason is really twofold. First, the perioperative risk, the risk associated with the open heart surgery itself, is significantly increased, especially in these often frail heart failure patients. Second, the procedure often fails to provide a clear long-term clinical benefit, particularly in the context of that advanced ventricular remodeling we keep talking about. Adding a mitral valve repair onto another surgery, like coronary artery bypass grafting, CABG, has been studied, and it generally hasn't shown improvements in survival or reductions in heart failure readmissions, while definitely increasing the surgical complexity and risk.
So again, the underlying sickness of the LV is often the dominant factor, and just doing surgery on the valve doesn't necessarily fix the core problem.
Exactly. The potential exception, interestingly, goes back to that atrial SMR subtype again. There is some limited data suggesting that isolated mitral valve surgery, either an annuloplasty ring to tighten the annulus, or even valve replacement, might provide significant MFR reduction and perhaps clinical benefit in carefully selected cohorts, where the primary driver is that atrial dilation and annular stretch, not ventricular failure. But generally, for the much more common ventricular SMR patient, the focus has really shifted entirely towards the less invasive transcatheter solutions. And the main one here is M-TEER.
Right, M-tier, mitral transcatheter edge-to-edge repair. That's the MitraClip therapy we associate with the big co-APT trial, which, as we discussed, was technically for severe SMR. But the evidence supporting its potential use in moderate SMR is really starting to build now, isn't it? Largely thanks to trials like ReShape-HF2.
Yes. ReShape-HF2 is a really pivotal trial in this context, mainly because it highlighted the real-world diagnostic challenges. As we noted earlier, it had the highest prevalence of moderate SMR among all the major randomized M-TEER trials. 53% of their patients actually had moderate baseline ERA, averaging around 0.25 centimeters time. Now, the trial was officially designed and powered to look at severe SMR, but the overall results still suggested that M-TEER led to a significant reduction in heart failure hospitalizations and also improved quality of life, measured by that KCCQ score, compared to just medical therapy alone.
Okay, so even though it probably wasn't statistically powered to prove efficacy specifically in the moderate subgroup alone, the overall signal was strong enough to at least generate a compelling hypothesis. maybe this moderate SMR leak is still clinically relevant enough in some patients to warrant fixing it.
That's exactly the hypothesis it generated. And that led directly to looking at observational data, real-world registries, to see what happens when MTIR is used in moderate SMR patients outside of strict trial criteria. The large combined expanded registry is key here. It specifically looked at outcomes for patients who received MTIR but had baseline moderate SMR that was about 39% of their whole cohort. And what they found was really quite important. They found that patients starting with moderate SMR had broadly similar outcomes after MTIR in terms of symptoms, quality of life improvements, mortality rates, and HF hospitalization rates compared to the cohort who started with severe SMR and got the same treatment.
That's fascinating. So it suggests that if you're a moderate SMR patient, but you're sick enough that the heart team is considering MTIR, meaning you've likely failed maximal GDMT and are still symptomatic, your outcomes after getting the clip might actually be just as good as someone who started with conventionally severe SMR.
Precisely. Now, we have to be careful. This is observational data, so it's hypothesis generating, not definitive proof like a randomized trial. But it provides really powerful justification for designing and conducting those dedicated future randomized trials, specifically for moderate SMR. It strongly supports the underlying concept that reducing the MR itself, getting the leak down, regardless of exactly how severe it was graded initially, is likely a crucial therapeutic goal for the symptomatic patient who hasn't responded to meds. And actually, a sub-analysis of the original COAP trial reinforced this idea. It showed that achieving successful MEN-AR reduction, getting it down to mild or less than moderate severity by 30 days post-procedure, was independently associated with better long-term outcomes, less death or HF hospitalization, irrespective of whether that reduction was achieved via the device or just through very aggressive GDMT optimization in the control group. Reducing the leak matters.
And we should remember, MTIR is just one type of transcatheter technology. What about other approaches, like devices focused on indirect annuloplasty? You mentioned the Carillon device earlier.
Right. The Carillon device takes a different approach. It achieves an indirect annuloplasty, meaning it tightens the mitral annulus by placing a device that cinches the coronary sinus, which runs right along the back of the mitral annulus. This cinching effectively narrows the stretched annulus and helps reduce the leak. The Already SOAP FMR trial was a properly sham-controlled study using this device, and it included patients with at least moderate SMR. The results showed that the Carillon device led to a significant reduction in the SMR volume and also promoted favorable LV reverse remodeling at 12 months compared to the sham group.
Interesting. So instead of clipping the leaflets together in the middle, it sort of cinches the ring from the outside in.
Exactly. And importantly, the clinical status improvement, particularly looking at quality of life scores, was notably pronounced specifically in the moderate SMR patients within that trial. This just confirms that there might be multiple different transcatheter strategies beyond just MTIR that could potentially benefit the right moderate SMR patient, depending on their specific valve anatomy and the underlying cause of their SMR.
Okay, let's try to synthesize all this evolving evidence. If you're a clinician today, what does the practical management framework look like for a patient who presents with heart failure symptoms and is found to have moderate SMR on their echo?
I think the framework has to be hierarchical, really. First and foremost, absolutely. Prioritize GDMT. You have to maximize guideline-directed medical therapy. That includes the foundational drugs, plus the newer classes like ARNIs and SGLT2Is, and you need to consider CRT or PVI for AF if the patient meets the criteria for those. This is the only way to treat the underlying disease process and potentially resolve the SMR completely, which, as we saw, happens in maybe over a third of cases just with good medical management.
Okay, but what about those patients who go through that initial intensive medical optimization phase and they still have persistent moderate SMR and ongoing symptoms?
That's the critical decision point, and that's the moment for the multidisciplinary heart team. Personalized decision-making is absolutely essential here, especially because we are currently operating outside of formal guideline recommendations, which still restrict MTIR mainly to severe SMR, grade 3+ or 4+. The team needs to utilize risk stratification tools and metrics to try and select the most appropriate candidates for a potential intervention, even with moderate SMR. This is where those advanced metrics we discussed become so important, things like a high regurgitant fraction, RFRAC perhaps 50% or more, or maybe a documented history of recurrent heart failure hospitalizations despite good meds.
So these characteristics essentially help identify the moderate patient who is clinically behaving more like a severe patient, someone who seems truly refractory to medical therapy alone.
Precisely. They help pinpoint those dynamically severe patients who carry that particularly poor prognosis we talked about. But because M-tier and other devices remain technically off-label for this specific indication right now, this brings us directly to the crucial need for dedicated, prospective, randomized clinical trials.
Yeah, it sounds like they are urgently needed to really clarify the role of MTR and potentially other devices in this moderate SMR population, and hopefully move these options from just hypothesis-generating observational data to actual guideline-supported therapy if proven effective. What are the key design challenges those future trials absolutely must address, based on what the review highlights?
Well, first, the inclusion criteria have to be incredibly rigorous. Future trials must adopt a strict multi-parametric approach for defining who gets in. They need to focus squarely on patients meeting those quantitative criteria for moderate SMR, like EROA 0.20, 0.29 centimeter dolars, ARVL 3044 ml, and perhaps incorporate RFRAC thresholds too. Secondly, they probably need to integrate stress echocardiography more formally, perhaps as an inclusion criterion or a stratification factor, to really capture that dynamic SMR component and ensure they're recruiting patients whose leak is truly limiting them functionally.
And maybe the most important lesson learned from the whole QOA-PT versus Mitral FFR, experience the need for that GDMT run-in phase.
Absolutely mandatory. That's probably the biggest lesson. Given how effectively optimal GDMT can reduce or even resolve SMR in a significant portion of patients, future trials must include a mandatory initial run-in phase where GDMT is aggressively optimized before patients are randomized to either the intervention arm or the continued medical therapy control arm. This ensures you are truly studying the effect of the intervention in patients who have genuinely failed optimal medical management and might need that targeted structural fix. Without that run-in phase, the trial results could be completely confounded by including patients who would have gotten better anyway, just with better medical treatment.
That makes total sense. Finally, the review points towards some emerging technological solutions that could potentially help standardize this notoriously variable diagnosis. Artificial intelligence and machine learning. How might they help?
Yeah, AI and ML tools are incredibly promising in this space, mainly because they offer the potential for more automated, objective, and reproducible assessment and risk stratification. We've talked a lot about how subjective interpretation and inter-observer variability have really plagued SMR grading for decades, leading to things like those high reclassification rates between local reads and core labs. AI models theoretically could be trained to accurately quantify SMR severity from echo images, track subtle changes over time, and maybe even integrate multiple parameters to predict risk with higher reproducibility than human readers. This could finally help standardize SMR grading across different centers and maybe overcome one of the key historical challenges in diagnosing and managing this condition.
Which could mean future trials would be much more reliable, and clinicians in practice would have more confidence in knowing exactly which category their patient truly falls into.
That's the hope, exactly. AI might provide that missing piece of standardization and perhaps even predictive power that we really need to feel more confident about intervening or not intervening in this complex, moderate SMR group.
This has been an incredibly insightful deep dive. It really charts a clear, evidence-based shift in how cardiology needs to start thinking about moderate SMR. Let's try to bring this all together as a final takeaway.
Yeah, I think the synthesis is pretty clear now. Moderate SMR is definitely common, it carries significant prognostic weight, and it's diagnostically complex. It simply cannot be dismissed as some sort of mild, insignificant bystander finding anymore. While optimizing guideline-directed medical therapy absolutely remains the unshakable foundation of care, the emerging evidence, particularly from observational data like the expanded registry and maybe even signals from trials like ReShape-HF2, strongly suggests that transcatheter options, especially M-tier, might offer real, tangible benefits in terms of quality of life and reducing hospitalizations for carefully selected, high-risk patients who remain symptomatic despite our best medical efforts.
So, given the dynamic nature of SMR, how the leak can change dramatically based on exertion or fluid status, and given the growing prognostic importance of more sophisticated quantitative measures like RFRAC, may be combined with advanced imaging like CMR fibrosis assessment.
The critical question, really, for future research, and frankly for every heart team evaluating these patients today, is this. Can we use these advanced imaging techniques, maybe combined with emerging AI tools, to reliably identify the specific features, whether it's a very high RFRAC or severe dynamic SMR on stress testing, or perhaps extensive myocardial fibrosis on CMR, that truly define the functionally severe or dynamically severe moderate SMR patient? The patient who really needs a targeted structural intervention before their underlying heart failure progresses irreversibly, beyond the point where fixing the valve can still help.
A question that really pushes cardiology towards more preventative, highly individualized, and precisely targeted intervention, potentially redefining what moderate truly means in clinical practice.
Indeed, it's an exciting and challenging time for managing this condition.
Thank you for watching The Funnel Effect.